Good afternoon, and welcome to this month's Northern Virginia Health Policy Forum. I'm Brittany Lockhart, Vice President of Health Policy at Applied Policy, a health policy and reimbursement consulting firm based in Alexandria, Virginia. My colleagues and I host these gatherings every month to explore critical issues shaping American healthcare. It has been more than 3 decades since Congress established the 340B drug pricing program to offset the unintended consequences of earlier legislative efforts to address rising healthcare costs. Enacted with bipartisan support as part of the Veterans Health Care Act of 1992, the program was designed to preserve safety net providers' access to affordable outpatient drugs. As the program has grown, it has come under increased scrutiny from lawmakers, regulators, and industry stakeholders, some now asking whether it may be generating unintended consequences of its own. Today, we welcome Greg Doggett from Powers Law, William Newton from the 340B Report, and Elizabeth Linderbaum from the National Association of Community Health Centers to discuss the program and the recent updates. Welcome, and we're excited to hear from you today. So to begin, could you all introduce yourselves and talk a little about how you got to this point in your career?
Sure. I'm happy to kick us off. Greg Doggett with Powers Law, and thank you to Applied Policy for organizing this panel today. I have been working on 340B issues since 2010. For the majority of that time, I worked at 340B Health, which is a national trade association representing around 1,600 hospitals and health systems that are participating in 340B. And I did a lot of work for them related to 340B compliance education, but also policy and advocacy work, both at the federal and state level and in both the regulatory and legislative realms. I also worked some for Walgreens on a broad range of health policy issues, including drug pricing and 340B. And I recently joined Powers Law in their 340B drug pricing practice, where I'm working with a lot of 340B covered entity stakeholders on 340B legal and compliance issues, but also 340B policy and advocacy issues.
Thanks so much, Brittany, for having us. My name is Will Newton. I'm an associate editor and senior writer with 340B Report, which is a trade publication focused on covering the 340B drug pricing program and drug pricing policy. I'm based in Washington, D.C., and I've been covering the 340B program here on a daily basis for about 3 years, focusing a lot on the debate about 340B rebates, state legislative action, federal policy, court cases, regulatory stuff, all related to the 340B program. And before joining 340B Report, I was working as a healthcare journalist covering drug development and regulatory policy for a couple of trade publications based in New York. And I'm really looking forward to this conversation today.
And I'm Elizabeth Linderbaum. I'm the Director of Regulatory Affairs at NAC, the National Association of Community Health Centers. Very excited to be a part of this important conversation. So how did I get here? It's funny. I feel like everyone, it's like once you're first introduced to 340B, it never leaves you. So way back in the day, I actually interned at 340B Health. So that's where I met Greg. And then since then, 340B has followed me in every career that I've had. So, worked at the Association for Community Affiliated Plans that were safety net providers with Medicaid managed care plans in limited amount of states. And they also focus on 340B. But then, obviously, now at the National Association of Community Health Centers, health centers are one of the covered entities, safety net providers that really benefit from the 340B program. And so it's, just one of the biggest areas of my portfolio, and worked at it mostly at the federal level, but also at the state level as well. So just, yeah, excited to be here and to dive into the content.
Thanks, guys. So for those who may be less familiar, what is the 340B program and what was Congress trying to accomplish by creating it? Will, could you kick off?
Yeah, sure. So, as you mentioned, the 340B program was established by Congress all the way back in 1992. And when creating the program, Congress said that the purpose was to help safety net healthcare providers, quote, stretch scarce federal resources as far as possible to expand patient access and provide more services. So, that was sort of the intent there. And then how the program actually works is that eligible healthcare providers known as covered entities, this includes nonprofit hospitals that serve a certain percentage of low income and Medicaid patients, as well as rural hospitals, community health centers, other clinics. These 340B covered entities can purchase outpatient drugs at a discounted price from participating manufacturers and then get reimbursed for those drugs at around the full price. And so this spreads sort of the difference between the 340B discounted price and then the higher reimbursement. That is known as 340B savings. And the idea is that these safety net providers, again, would use those 340B savings to stretch scarce federal resources and expand patient access and services. So that's kind of the basic nuts and bolts there.
Yeah, and I'll jump in and just say that, building off of Will's point, that it was really intended to help those safety net providers. And as he mentioned, community health centers, I think, was one of those key providers because we are supposed to be providing care to folks regardless of their ability to pay. We get money from the federal government to kind of offset a lot of the uncompensated care that we provide. But then obviously, if we're trying to, be that community hub for patients and provide even like not just healthcare services, but enabling services, wraparound services. The 340B savings that we get through the program are directly invested back into patient care. And that's also goes back to, any type of like federal funding that we get, like statutorily required, we have to reinvest that back into patient care. And, having that flexibility has been really crucial for us. So just wanted to kind of add a little bit of color from my organization's perspective.
And I think just one thing that I would add is I think that, especially for folks that maybe are new to 340B or have not spent a lot of time working on the program, there's such a broad range of providers in 340B, as Elizabeth mentioned. You have community health centers, but you also have a variety of different types of hospitals, hemophilia treatment centers, Ryan White clinics, AIDS drug assistance programs, and that's just a few of the covered entity types. So there's a lot of different types of providers and programs that benefit from participating in 340B.
Great background. Thank you. With that, could you maybe explain a little how the program works in practice for a manufacturer or a covered entity, but most importantly for the patients?
So I know Will touched on this a little bit, but in order for a manufacturer to participate in Medicaid or Medicare, they would have to participate in the 340B program. So again, offering that drug at a very discounted price up front. And then the covered entity, like the health center, is able to bill a payer at the non-discounted price to get these drugs. And then with that, those savings, we're able to really expand services that like dental, behavioral health. We are able to invest in community initiatives like maybe having a food pantry for our patients, extend our operating hours to better meet patient needs. And then, of course, we are able to offer very steeply discounted or free medications to eligible patients. We also have patient assistance programs at both our entity-owned pharmacies and then our contract pharmacy partners can also utilize these savings to support maybe non-revenue generating services like community health workers that aren't reimbursable providers, social workers, navigators, even helps with our pharmacists that are providing some of the patient education around medication management, answering any questions, and then also expanding or adding care coordination enabling services. So I think that, what obviously with 340B, it's really focused on, getting those medications at a discounted drug or discounted price, and then you're able to kind of assess your patient population's needs across the country and, better serve them. So health centers right now serve over 34 million patients across the country. 1,700 health centers with over 17,000 individual sites. And so having that flexibility, the health center can really better meet their community's needs based on that diverse patient population that they're seeing. So kind of, I know it's a very wonky issue, but it's been around for over 30 years, and I think has generated a lot of bipartisan support about how, being transparent about where we're actually putting our savings.
Yeah, and I would add, just covering this from a journalist perspective, sort of how the program is working in practice right now really depends on a lot on who you ask. And so certainly from the provider perspective, and Elizabeth did a great job explaining this, all providers will argue that it's really kind of a lifeline and that 340B savings allow them to fund so many services for patients that otherwise would be in the red and they would not be able to fund without the program. Some of the critics of the program, particularly among manufacturers, would argue that there's not enough transparency in it right now, particularly for some larger hospitals. And so there are also some arguments out there that the program has grown in size quite a bit, but there has not necessarily been sufficient transparency to ensure that patients are benefiting from it. And so these are a lot of ongoing conversations that are happening right now. Different stakeholders feel very different about the program. And so that's also kind of an important thing to consider as well.
Yeah,
Okay.
definitely. That's what makes it so interesting, right?
Yeah, and I was just going to kind of add, to what Will said. I mean, again, I work primarily with providers, but I've been working in the space a long time and have, definitely gotten a lot of information from the manufacturer perspective. Obviously it places obligations, on manufacturers, practically speaking. They have to, make sure they're providing pricing information to the government, and the government makes that information available to covered entities, through a secure database. They have to make sure that their distribution channels, whether it's a specialty distributor or a wholesaler, is providing that pricing to covered entities. And then, kind of building on what Will said, they're also sort of playing their own, kind of oversight function in addition to the oversight role that the federal government plays. So they will, sometimes do audits of covered entities. They might sometimes do inquiries where they'll ask certain questions of covered entities about sort of, how the covered entities are staying within the rules of, for example, how only certain patients are receiving, 340B drugs. And then I think also too, there's also sort of a difference of perspective, I think, generally between covered entities and manufacturers on sort of, what the program was intended to do, and then sort of how the program should ideally operate.
Great. Thanks for that perspective. So recently CMS had announced a 340B rebate model, where the participants would be those manufacturers that we were just talking about. Given the complexity of this program and how much has occurred in the past year, I think it might be useful to level set with the audience a little bit. Could you explain, Greg, a little bit about the model that HRSA announced and what's been happening since that announcement?
Yes, happy to. So last year, HRSA announced that it was going to be conducting what it was calling a 340B rebate program pilot. And this would be a fundamental change to how the program has largely operated over the last 30 years, because covered entities historically have accessed these 340B ceiling prices as upfront discount. So when they buy the drug from a wholesaler, they're paying whatever that discounted price is. And what this model would have done is, instead of getting the 340B ceiling price as an upfront discount, a covered entity would sort of pay like a regular list price. And then on the back end, after that purchase, they would submit 340B claims data to a manufacturer, and then the manufacturer would provide access to the 340B ceiling price in the form of a rebate. Now, HRSA was proposing to not do this for the entire program. it would have just been for 10 drugs. These are the first 10 drugs that are subject to the new Medicare price caps or negotiated prices that went into effect on January 1st of this year. Covered entities, when this announcement came out, were very concerned about, how this would financially impact them because they would have higher upfront cost, the administrative burden of having to manage 340B as a rebate program, or at least part of 340B as a rebate program instead of an upfront discount program. And so the covered entity community, I would say, largely opposed the pilot, and then there were some covered entities went so far as to actually sue the administration in December, saying that the administration sort of violated federal rules. And a couple courts ended up agreeing with those covered entities, stating that the federal government did not really fully consider the impact of the proposal on covered entities, and that they didn't provide a reasonable explanation for their change of policy. And what ended up happening is the federal government and the covered entities that participated in that lawsuit kind of agreed that the federal government would sort of abandon that guidance that it came out with last year, and that if they were to kind of pursue a new rebate program, they would kind of go back to the drawing board. So that guidance from last year is no longer in effect. No, it didn't go into effect on January 1st. We don't have a rebate pilot right now, but in just the last couple of weeks, HRSA has come out not with a proposal sort of laying out exactly how they would do a rebate program, but it's a request for information where they're seeking a lot of data and information from all 340B stakeholders, including manufacturers and covered entities, on sort of potentially doing a new rebate program of some sort.
Yeah, and just to give some color on just how kind of abrupt and how much sort of a roller coaster this has been for 340B stakeholders. So this pilot was supposed to take effect on January 1st, and a court actually blocked it from taking effect on December 29th. So, basically just 2 days right before then. So it was a very, very sort of abrupt shift. And back to what Greg said about how this rebate pilot would have applied to just the first 10 drugs subject to Medicare drug price negotiation. There's now sort of this interesting space where manufacturers and providers are sort of figuring out how to deal with the implementation of Medicare drug price negotiations and how that looks in practice. And then to your point also about kind of this new process HRSA has started, it does seem like from some people I've spoken to that although they have not actually proposed any concrete second pilot, it looks like they're very much kind of laying the regulatory groundwork to do this again and trying to check all of the boxes and be particularly careful this time around so that when they in theory propose another pilot program, it would have stronger legal footing than their first one and maybe could withstand a legal challenge that this first one did not.
Yeah, and adding on to that, I just think the difference between the original rebate pilot program RFI and this one has like 7 categories full of questions that are requesting very specific feedback and data on the implementation and the impact of the rebate. And so it's asking about like one-time costs versus ongoing costs around staffing, FTE, external consulting costs, what it could mean around, the specific costs around the first 10 Medicare negotiated drugs, around cash flow, around what it would mean for TPA implementation. Like there's just such a granularity of detail that is requested. And I think I agree with Will that they are being very intentional, looking back at the comments, seeing what the responses were around and trying to better tease out some of the information so that they have that record that they at least asked about these things before moving forward.
Yeah, that's exciting, interesting update with this new RFI. Um, One of the bigger concerns with the original proposal had to do with the use of technology and data collection, or potentially the use of third parties to collect data on behalf of um, manufacturers to be sent and shared with CMS. Um, could could I get your guys' kind of take on what role do you see technology playing in the future of a rebate model or in the future of 340B? And what other challenges do you see in a shift to this type of rebate model?
Sure, I can start by taking a first stab at this, but I know we mentioned earlier with the rebate model that there would be a lot of claims data that covered entities would be required to submit to manufacturers in order to receive the 340B discount as a post-purchase rebate. So there's certainly the question about the data itself and sort of what type of burden that would be on covered entities to submit. But there's also this question about it's a ton of data to process. Who is responsible for actually processing and going through the data? And so when we look back to HRSA's first rebate pilot proposal, it said that manufacturers that participate, they would be responsible for all of the IT and software costs. And as a result, they would sort of get to hire and select the vendor administrating it. So under the old rebate pilot that's now been abandoned, all of the manufacturers chose a technology vendor to sort of be responsible for setting up this portal to submit claims, verifying claims, etc. And from the manufacturer's perspective, going back to what Greg said earlier about them sort of having obligations under the program, they feel that it makes the most sense for them to have access to that data and to make sure that there aren't duplicate discounts and that the claims are all valid. From the provider perspective, though, there are a lot of concerns about basically handing all of this data over to a vendor that is, hired and a client of drug manufacturers, because there's some concerns that this sort of puts manufacturers in kind of a regulatory role where they would be the arbiter of what claims are valid, what claims aren't valid. And there are also some sort of concerns about that. And so I know I think we're going to touch on this later as well, but I know covered entities have certainly been advocating for an alternative where a neutral third party, likely contracted by the government, would be the one responsible for implementing this technology. So that's sort of another one of these interesting, very wonky debates playing out right now.
And I think that yeah, just getting into a little more of the details, I think of the role of technology for covered entities. I think that assuming that a rebate pilot or rebate program of some sort is put in place, I think it's going to be this balancing act of figuring out that what can be potentially automated in terms of data reporting, while also still probably having to invest a substantial amount of time in sort of managing the rebate program. So for example, maybe the data submission is sort of automated and they sort of work with some of the technology vendors that they already use to manage all of their data for the 340B program. But if it comes to their certain claims where maybe they didn't get a 340B rebate and they think they should, that process may not be automated and they may still have to sort of figure out how they're going to staff that function of investigating those situations, working with the vendor, working directly with the manufacturers. So I do think technology will play a critical role, but I think there's also probably kind of no getting around the fact that it's also going to just create kind of new workflows that can't be completely automated.
I agree. And sorry, I'm off camera. I have some internet instability in the office, but wanted to mention that, yeah, we are definitely very concerned about the operational and administrative impact this would have. And obviously, we'd have to be working with, third party administrators that already have been helping with the claims, try to pivot and create financial like software that will actually be compatible with a rebate pilot program. And it'll be interesting to see how much time will be given from whenever this is probably going to be announced to the implementation, because the last rebate pilot program, it was going to be implemented within 60 days of being finalized. And so, that's something that health centers and other covered entities are trying to grapple with and trying to work with some technology consultants, TPAs, to figure out how they can anticipate what is all needed to be done so that they're not scrambling at the last minute.
Yeah, good point about the timing of it. Um, you all at some point, I think, have sort of touched on the IRA drug pricing. In addition to uh, those negotiations, are there other federal policies or payment programs that we should be thinking about and how they might intersect with or influence how 340B operates?
Yes, there are, and I probably should kind of back up a little bit, and just maybe for those that haven't been following these issues as closely, um, the reason that HRSA selected those first 10 drugs for the rebate program is that as part of the implementation of the new maximum fair prices, these new Medicare negotiated prices, manufacturers are protected from having to provide both a 340B discount and this negotiated price on the same claim. And so HRSA was looking to use this rebate model as a way for manufacturers to figure out, okay, do I have to offer a rebate to effectuate this new Medicare negotiated price, or is my obligation just to provide the 340B price? It was a way for them to kind of avoid this sort of double hit that is, again, that they're protected from under federal law. Similarly, there is a big intersection with the Medicaid program, specifically the Medicaid drug rebate program, because manufacturers don't have to provide both a Medicaid drug rebate to a state and a 340B discount on the same claim. So there are sort of federal rules around what covered entities have to do to protect manufacturers from these Medicaid duplicate discounts. There are also state rules around what covered entities have to do. So it could be, for example, just acknowledging that you're using 340B so that your name will go into a file and there's transparency around you using 340B as a covered entity. There might be claim modifiers that you have to apply to a claim so that a state Medicaid program has that information when requesting Medicaid rebates. And then while generally there's not a lot of rules around what Medicaid pays for 340B drugs, there is rules around what some 340B drugs are reimbursed at, specifically 340B drugs that are dispensed by retail pharmacies. In short, basically, they're reimbursed based on their actual acquisition cost. So what they're getting reimbursed is kind of closer to what they get paid for those drugs.
Yeah, I think one other potential area where there could be some intersection, and this is a pretty new development, is we're seeing some of these direct to consumer platforms. I know Trump RX was recently come out there. There aren't many drugs on these platforms right now, and they don't directly touch on 340B, but would have quite a bit of implications there. And the reason is that, as we discussed in the beginning, 340B savings are when a provider gets a discounted price and then can reimburse at the full price. If we start seeing more platforms come up where consumers basically buy drugs directly from manufacturers through these types of platforms, then that would mean that the providers, the covered entities, aren't retaining 340B savings on those drugs. At this point, it's so early, there's not a lot of uptake, so it's tough to say that there's been much of an impact. But certainly, if direct to consumer starts to proliferate more, that would have some important 340B implications.
If we can move on a little bit, with regard to the OPPS acquisition drug survey, could one of you explain a little bit what's the goal of this survey and what are the considerations for providers who are subject to it?
I'm happy to take that question. So, essentially what this requires is that for drugs that are, separately paid under CMS's Medicare outpatient prospective payment system, and we're mainly talking about hospitals here, they will have to, well, they're being asked to provide their 340B acquisition costs. I think it's worth mentioning, though, that this survey is not limited to just 340B. So even if you're a hospital that doesn't participate in 340B, you're going to have to provide that cost information. I think broadly speaking, I think CMS is trying to get sort of more information, more transparency around what providers are paying for these drugs, because these drugs are not reimbursed based on the actual prices that providers are paying. It's reimbursed based on a certain drug pricing benchmark with a 6% markup. I think that there is thought that they may, in the future, want to change the reimbursement formula so it is more tied to the actual prices paid by providers. And specifically when it comes to 340B, I think there is interest and potentially sort of not just sort of lowering reimbursement sort of across the board, but maybe having a two-tiered reimbursement where if you're a provider that's using 340B drugs, your reimbursement, again, that would probably be based more on your 340B purchase price would be much lower, closer to that 340B price. And there is some precedent for this. The first Trump administration had also done a payment reduction for these drugs. That ended up being legally challenged by hospitals. The case went all the way to the Supreme Court, and the Supreme Court actually sided with providers and said that that payment reduction was illegal in part because, well, really in large part because CMS did not do the kind of information gathering that comes from a survey. So I think the thought here is that, kind of like HRSA with the rebate model, CMS may be going back to the drawing board to try to do something in a way that would be more kind of legally defensible if it were legally challenged again.
Yeah, I think that's a great point that it does ring very familiar to this two attempts at the rebate pilot because, as you said, CMS did cut Medicare Part B reimbursement for 340B hospitals pretty significantly. That was overturned for some procedural reasons, and now this survey seems like it's very much, again, CMS is checking all of the boxes this time. So if it does go to this two-tiered system where 340B hospitals are reimbursed less than other hospitals for Part B, there would be a stronger legal footing again. So I think that that's something that, yeah, we should definitely be closely watching.
So, with respect to Congress, then, while much of the action regarding 340B has really been within the executive branch with CMS and HRSA, is there any movement in Congress that we should be tracking?
Yeah, I can start off. There are definitely a couple of bills that have been in the ether 2025, 2026. There was a bill that came out in 2025 that was trying to protect 340B covered entities by prohibiting manufacturers from restricting 340B pricing to contract farm or covered entities and contract pharmacies. So restoring contract pharmacy access for covered entities. Another bill that we've been tracking is from Reps Jack Bergman, who's from Michigan, and Jake Auchincloss from Massachusetts, that are leading a bill to exempt health centers from 340B rebate models. That has about 42 co-sponsors. So, obviously we're tracking that. And then I have also heard, and who knows if this will happen, but HRSA could schedule a congressional briefing on the impact of the 340B rebate model on patients' access to medication. That was a requirement from the Consolidated Appropriations Act, and obviously something that we're very interested in given the anticipated impact to health center patients and other patients across the country. So those are the things that have been kind of on my radar. I don't know, Will, Greg, if there's other things that y'all have been tracking.
Yeah, I would add that in addition to the bills you've mentioned, there have been a lot of discussions and even some hearings on the 340B program. Just yesterday, the House Energy and Commerce Committee, which has jurisdiction over the 340B program, held a hearing on healthcare providers' role in the US healthcare system, and the 340B program came up several times. There are some big exchanges there. An important Senate committee held a hearing specifically focused on 340B last fall. And so there's a lot of these discussions, there's a lot of these bills, but the one thing we really haven't seen that much is a lot of actual concrete action and votes on 340B legislation. And from speaking to health policy people, it seems like the consensus is that that's probably not going to change, at least for this year, for two main reasons. One being that the House and Senate have historically close margins, so there's not a lot of wiggle room there. And then the other, probably more important one, is that it's an election year. A lot of members are going to be campaigning, and there's not really a huge appetite, it seems like, for there to be kind of an extended, prolonged healthcare debate in Congress right now. That said, though, given, this bill Elizabeth mentioned with 42 co-sponsors, given all these hearings, given that there are several senators and representatives who are very, very focused on 340B, do expect these conversations to continue, and there is a pretty decent chance that some kind of big package will come in the next couple of years.
Yes, I concur with Will that I don't think for all the reasons that he listed, much legislative action is likely to happen this year. But I think that, this might be a prelude to what, could happen next year because there are, some legislators, including some in very kind of key important positions, such as Senator Cassidy, who is the chair of the Senate Health Committee, which has primary jurisdiction over 340B, who continues to focus, kind of really closely on the program and, has been sort of, vocal with some of their concerns and criticisms.
Great, thank you guys. So we've just covered a lot of what's been occurring at the federal level with regard to 340B. Let's switch to state policy. Several states have passed laws related to contract pharmacy protections. Would one of you give us a little background on what these laws are trying to accomplish?
Sure, I can start off. And just for some quick context on this, there are 21 states with these contract pharmacy access laws, and 13 of those states enacted them last year alone. So this has been a ton of momentum for this, and this is a very, very recent thing. But to sort of step back and understand how we got here, basically, HRSA for a while now had said that if you are a covered entity and you contract with a third-party pharmacy, this could be like a CVS or Walgreens or like a mom and pop pharmacy. If one of your patients goes there and you have a contract with them, you can still get the 340B discount for those drugs. And so covered entities had been using contract pharmacies for a while. And then starting in 2020, some manufacturers stepped in and created policies, and they basically said that they were going to put some restrictions on the delivery of drugs to contract pharmacies. A lot of them saying you can only use one contract pharmacy or only ones within a 40-mile radius, things of that nature. There were some lawsuits related to it, and ultimately the courts largely sided with drug manufacturers and basically said that the 340B statute is silent on drug delivery, so drug manufacturers can put some reasonable restrictions on contract pharmacy delivery. As a result of that, a couple states stepped in, starting with Arkansas a couple years, and basically said, okay, if the courts are saying that the 340B statute is silent on delivery, that means that we can create our own delivery laws. And so we now have 21 states that have enacted laws that prohibit drug manufacturers from placing restrictions on the delivery of 340B drugs to these contract pharmacies. There have been a ton of legal challenges related to these. Every single one of these 21 laws has faced multiple drug manufacturer lawsuits. We're starting to see some court rulings come in. So far, the majority have sided with the states, though there have been a couple examples where they've sided with drug manufacturers, Oklahoma and West Virginia coming to mind. but a lot of these cases are ongoing or under appeal. And so there's a ton of active litigation all the way up into the federal appeals court level that could really sort of determine the future of these laws. And even this year, we're expecting, any week now, Washington State to become number 22. So the state level has been incredibly active in the 340B space.
I would just add sort of two kind of just interesting developments on top of what Will shared. One is that there was an interesting twist lately where the federal government, which had, largely stayed out of these legal battles between states defending these laws and manufacturers trying to challenge them, the government submitted an amicus brief in some of these cases, basically saying that they agree with the manufacturers that the federal 340B law does preempt states from enacting these kinds of laws. Specifically, they say in their amicus brief that, they think that these state laws discriminate against manufacturers that can participate in 340B compared to those that don't. And they express concern that these kinds of laws could potentially dissuade manufacturers from participating in Medicaid and Medicare Part B. For those of you who, don't, necessarily spend a lot of time in the legal world, an amicus brief is basically a document that an outside party will submit, sort of trying to provide helpful information to a court as a court considers an issue. So it's not like a court necessarily has to, follow sort of what the federal government is saying in this amicus brief. But I think, anytime the federal government weighs in regarding sort of how a federal law that it's responsible for kind of implementing and overseeing what their view is on that law, I think that a court, will pay attention. So it'll be interesting. And I think just the other thing that I would note is I think sometimes people get a question of like, well, when are we going to get a resolution, on sort of all these, cases? Is like the Supreme Court eventually going to decide? And I think what I would say is that there was one decision coming out of one appellate court that sided with the state of Arkansas, and PhRMA, the trade association, had requested the Supreme Court review that decision. The Supreme Court declined. They didn't provide an explanation. I think that the Supreme Court doesn't take up most cases that they're asked to consider, but it'll be interesting, if eventually, and who knows if it'll happen, if, there's sort of another appellate court at some point that decides another way, that maybe they strike down a state law, that would increase the odds that the Supreme Court may revisit the issue and would consider taking up the issue. But for now, it's sort of locked into these legal battles at the appellate court level and the district court level.
Yeah, and I'll just add to that, from my organization's perspective, we're very excited to see these contract pharmacy protection laws go into place, and we do use 340B report to track those. Contract pharmacies are so important to health centers because it's very expensive to like open your own entity-owned pharmacy and offer these discounted drugs at the health center itself. Maybe they don't have the finances, maybe they don't have the space to actually build their own pharmacy. And so, we do contract with a lot of smaller or, some of the national chains that are located near our patients so that they can pick up those meds. And so that's, we always are really excited to see states, pass those laws. And then, another area in the state that has been, we've been focused on is provider level reporting laws. So I know that we've talked about, I think, Will, you talked about that there's been a big heightened scrutiny around how covered entities are utilizing their savings. And so there have been a number of states that have implemented provider level reporting laws where either it applies to all covered entities or certain types of entities reporting, how much they're spending in 340B, where those savings are going. And so, while the federal government is really interested in enhancing transparency, it seems like a lot of states have been focused on that as well. Minnesota, for instance, I think this is the second year that they've published by covered entity, some of those transparency requirements. And so that's like another area that we've talked a lot about the federal level, but some state level legislation that is important to track as well.
Yeah, and I think to what Elizabeth said, like these state battles might sort of be a potential preview of what a compromise in terms of what we might see at the federal level could look like. And so we have these contract pharmacy protection levels that providers have been really advocating for. And then we have these provider level reporting laws that require covered entities to report additional information about their 340B programs that manufacturers have been advocating for. And we've started to see in some cases, some states enact both of these at the same time. So this Washington state bill that's sitting with the governor right now is a great example of it. It included contract pharmacy protections as well as both covered entity and manufacturer reporting requirements. Colorado is an example of a state last year that passed a law that included both contract pharmacy protections and these additional provider reporting measures. And so as we see this happen more and more in states, I think this could be potentially sort of the compromise type legislation, or at least sort of a framework for what it could look like on the national level.
Okay, well, let's dive in. We do have some live questions coming through. One of them was, could you share some insights on how the MFN, the Most Favored Nation deals, interact with 340B pricing, I guess, absent the rebate program?
Yeah, I'm happy to take a first attempt. So basically, these most favored nations policies, it has been an objective of the Trump administration to get to basically require manufacturers in the US to charge US patients similar prices to what they charge patients in select comparable countries in Europe and in other parts of the world. And there have been a lot of deals between the administration and manufacturers about related to most favored nations pricing. We don't have a lot of specifics on what they actually look like because none of the deals are actually public. But again, going back to what I said earlier about kind of the direct to consumer pricing, the real 340B overlap would be if we start to see more deals that involve lowering list prices. Sort of one of the weird, convoluted implications of that is that if list price is lower, then the 340B savings that covered entities rely on also lower because it's sort of a result of the spread between the two. So that's one of the things where it's way too early to tell how prevalent this is going to be, what's actually in these deals, but it could have some 340B interactions down the road.
And I think that I would just add, this is more kind of on the political side. I think that there is, some concern in the covered entity community, not necessarily the administration has come out and said this and manufacturers haven't as well, but I think that, manufacturers do feel like they've tried to work, with the administration on supporting the administration's drug pricing initiatives, including through these deals negotiated between some of the largest companies in the administration. So, I think the concern is that, the manufacturer community may be, asking the administration to support it on a variety of issues of concern and priority to it. And that may extend, to 340B on issues like the rebate model or the ability of manufacturers to, establish certain limitations on the use of 340B or certain kinds of reporting requirements, for 340B. So, even if there's necessarily a clear direct impact, it may sort of, affect sort of how the administration views and prioritizes the program.
Thanks. One more, well, two more questions for you. What are the biggest uncertainties that you think are facing the 340B program or will be facing the 340B program over the next few years?
Yeah, I can start. I think we covered a lot of them during this webinar. The number one thing is how are we going to be getting access to 340B price drugs? Are we going to have to pay for the full price up front? Or are we is it going to be operating in the same way as it is now? I foresee that as we've talked about, there's probably going to be some sort of rebate pilot program. What the scope is, it's unclear, but I think that's one of the biggest uncertainties. And the second one, which we talked about briefly at the state level, is the access to 340B price drugs at contract pharmacies. And is there going to be a limitation on the number of contract pharmacies that covered entities can utilize in the 340B program? And is that going to be, more highly regulated because of, and there's going to be any sort of resolution, maybe because of legislation or the courts? I think that those are two of the biggest areas I foresee.
Yeah, I think one of the really interesting things about the 340B program, if you actually look at the statute, the text of the law itself, it's very short. It's only a couple of pages, and this is really small compared to some other drug pricing programs like Medicaid, Medicare in particular, that are much, much longer. And so I think the fact that the statute itself is so short, but it has such enormous implications for US healthcare safety net is one of the reasons why we're seeing so much disagreement and differing interpretations of sort of how the program should work and its intent between regulators, manufacturers, providers, and courts. And so I think what we're already seeing now is that because the statute is in many ways kind of vague, so many key interpretations are playing out right now in the courts, and both providers and manufacturers, we've already listed so many different lawsuits, are increasingly turning to federal courts to try and advance their priorities within the program. And so sort of moving more and more into a world where there is just every new regulation draws a lawsuit and the courts end up being kind of the main arbiters of the program. I think that lends itself to a lot of uncertainty and something that we're following closely.
There's one emerging area that I would highlight too. So I think as we've, covered for a few years now, you've had some manufacturers that have had restrictions in place around contract pharmacy and have granted varying degrees of access to contract pharmacies in exchange for the submission of 340B claims data from covered entities. So what we've seen in the last, I think, 6 months, we've seen a couple of manufacturers start to say, if you want access to 340B pricing on any of our drugs, you'll have to provide us 340B claims data for all of them. And covered entity community has, been concerned about, again, sort of having to provide all this data. I think many of them feel like it's not really supported by the 340B law, and they've, raised concerns with HRSA, and, to date, HRSA, has sort of not taken any kind of enforcement action that the public is at least aware of, or has not sort of publicly commented on it. But we are really kind of right now in the middle of where if some of the manufacturers follow through on their, send us the data or else you may not get 340B pricing, we potentially could see manufacturers start to cut off 340B pricing. I've not heard of that actually happening, but it potentially could. And I think if HRSA doesn't sort of step in, you could see potentially more manufacturers going that route. And I think that if some manufacturers do start to cut off pricing, I think you're going to kind of see a whole new set of, legal challenges, or at least covered entities trying to figure out how to advocate against those policies.
Great, thank you. Last question for you guys. What is the one thing that you would like our audience to remember from our discussion today?
Yeah, I guess one thing is that I think it's sometimes easy to think of the 340B program as sort of existing in its own silo. It's a very niche program with specific rules, et cetera. But as we've discussed with the interaction, with potential Medicare Part B cuts, the interaction with the Inflation Reduction Act, Medicare drug price negotiation, potentially most favored nation, direct to consumer models, is that when looking at the 340B program, it's really important to look at how it interacts with other federal drug pricing programs, because Medicare, Medicaid, 340B are just with time becoming more and more interrelated. And so any change to one of them is certainly going to have a lot of ripple effects in every other program as well.
And I can jump in next. One thing that I think, would be a good takeaway for folks to remember is that 340B seems like it's a really complex program, but at the end of the day, it's just such a lifeline for the covered entities that participate in it, like health centers. I think with the rising healthcare costs, and there's so many other things that are happening in the ether that are impacting just general healthcare costs, that the savings are just really helpful for like safety net providers that operate on very razor thin margins to meet patients where they are. And that while there are all of these changes that are happening, just knowing that a lot of providers really keep patients at the center of it. And that we're all trying to work together. We know that the 340B program can't stay stagnant. It's been around for over 33 years, so there's bound for changes to happen, but to just keep patients at the center of all of these conversations.
And my closing comment, which kind of might be most applicable to those that are relatively new to the program or maybe have only started working on 340B recently, is if all this seems dizzying and complex, I would say it is. There's just so much going on. I mean, I've been doing this for 16 years now, and I find it a lot to keep up with, even though I have sort of so much historical knowledge and context. So, just if you're trying to learn about the program, stay at it. It keeps you on your toes all the time.
Thank you all so much. This brings us to the end of this month's Northern Virginia Health Policy Forum. Thank you, Greg, Will, and Elizabeth, for this dynamic conversation. Before I close, we just sent a message in the chat with links to subscribe for our monthly newsletter and view our Northern Virginia Health Policy Forum website for more in-depth insights into current and perhaps future health policy. Thank you for being here and enjoy the rest of your day.